I got a crazy question for you. This is an EMS testing question, and the students just were exposed to one like this. And the question goes like this: You're called to a football field for a male on the sidelines who went down, and the crowd witnessed it happen. You were there, standing there, witnessed it happen. You open his shirt up, and he has a pacemaker. Should you start pacing the patient because it's probably a pacemaker fail, or do you go right to CPR and defibrillation?
So does this person have a pulse?
No pulse. So there's no mechanical capture there, but when you put your fast patches on, you see that the pacer is just not working. And he's asystole.
So in that situation, it's if the pacer failed, they would just be going into like complete heart block or something. So it would be a PEA.
Whatever was put in for.
Exactly. But if they're asystole, it's because the patient just died for some reason, and you should just work it like any other cardiac arrest.
And the answer to the question is you override the pacer with your own, and I disagree with it. So
I would disagree with that as well, because that doesn't make sense.
Yeah.
Because otherwise, then we should be pacing every asystole, which won't work.
Right.
And I'll show you the question because the same question is written with an A instead of an and it's do CPR. It's really weird.
It's bizarre.
Because basically, if that patient, if you told me, well, it looked like he was in complete heart block, he had a pulse, but it was weak, then
that
absolutely,
scans.
that is true. That's a bradycardic patient who's in shock. Please pace them, not atropine, just pace them.
But that scans. That's
Yeah.
why they bought
That
the
makes
pacer
sense,
to begin with.
100%.
Right.
Yeah.
Yeah. If they're asystole, no pulse, it doesn't matter if they have a pacer under their skin or not. We're still going to just start CPR.
Just don't put the pads right over the device, and it's fine.
Yeah.
Or they're in said bradyarrhythmia, and there's no pacer spikes, despite the fact that they've got a pacer. Then they lost a wire, right?
Right.
Yeah, that's true.
Right. Then it's pace away.
Right.
But
But you're still going to have something with some type of a pulse. I mean, if there's pulseless, we're doing CPR.
Right,
And
exactly.
Yeah. It's just a bad question.
It is. It's
I
a really
think
bad
so.
question.
I think so. But it's just funny to me that it's written twice with the same different answer. So, Lucas and capnography.
So in the post-arrest period, leave them both on. I mean, there's no reason to take the Lucas off. I mean, if they die again while in the post-arrest period, it's very easy to click a button and boom, you have good CPR going versus scrambling to say, oh crap, let's get Lucas on. This person's in arrest.
Start
and then
over, yeah.
with end tidal, your goal in the post-arrest person is to have their end tidal be normal. So we want to make sure it's kind of as close to 40 as possible, and to make sure we're not hypo or hyperventilating them. So if you don't have end tidal when you are working the patient, absolutely they need end tidal in the post-arrest period.
I think every patient should get end tidal. I just think it's one of those amazing things that we don't often get, but now we're getting better at it.
Yeah.
But I think the protocols for ROSC have somewhat changed now to reflect that Lucas is probably going to generate quite a bit of capnography.
Are you okay? So you're edging up.
I'm trying to.
You're edging up to the
Greater than 10.
the less than 10.
It was kind of my lead-in.
So let's just qualify that to begin with. So in the protocol, historically, it said if your capnography was less than 10, that was a necessary thing to do a field termination. That was actually one of the requirements, and then that got softened. That got softened up now 2, 3, 4 years ago. I can't remember at this point. That is still, the number is still relevant, right? Because you probably don't have a salvageable person, if it is less than 10. As a matter of fact, we were all talking with John here a little bit ago, and that's still in there. But that's still true. If you put a Lucas on somebody, you will likely see higher than normal intra-arrest CO2s. However, if you see less than 10 with the Lucas on, that is probably a very non-salvageable.
Prognosis.
That's probably not a salvageable
And so
patient.
in general, we have all those rules listed, at least in our protocol for field termination. But remember that if you call med control, you're allowed as an EMS provider to do anything within your scope of practice. Right. So if you call med control and say, hey, the protocol says we shouldn't terminate for this, but my impression based on X, Y, and Z is meaningful outcome and recovery is almost 0%. I would like to terminate. Do I have permission? And that medical or that physician is allowed to say, completely agree with you. Time of death is right now. Let's terminate. And that's a good choice in that situation.
And it's not a mandate anymore, right? It just says in there, and if somebody's listening and they fixated on that because they practice it for a long time, it's just in there as, this may be a helpful tool in making that decision rather than saying this is an absolute.
Yeah,
Well,
and our protocols are not secret, by the way. If you're not with university hospitals, you can go to uhems.org and download our protocols. They're not secret. So anything we're talking about when we talk about UH protocols, you're more than welcome to scan through them.
Well, the other thing too, they hear 10 a lot because the ACLS teaches 10 too. So they're like, if you're doing CPR and your end tidal is less than 10, and it must be inadequate CPR, and it's like. Okay, yeah, there are some things you could correct with, are your hands in the correct place? Is your Lucas placement correct?
Maybe it slid down a little bit.
Maybe it slid down. That's another thing we have to pay attention to. You
gotta have that extra.
And some of those patients that are obviously going to be expired for whatever reason it is, then, it's not necessarily going to be greater than 10.
Or you're doing everything right and they've blown a ventricle, or there was some catastrophe, a big, massive PE, right?
Yeah.
And you're never going to get there.
Nope.
Yeah.
Or during CPR, you could have lacerated the liver, the spleen, and obviously if you bleed to death, which can happen in arrest because of good CPR, a medical patient just bled to death because of that. And that happens.
That's exactly what I was going to say. I have a patient who has an extended abdomen after CPR, and she's not getting back.
And the end tidal keeps on going down because there's just no circulating blood volume.
There's a story there.
And you can hide a lot of blood in the belly.
You can hide all of it in the belly, as a matter of fact.
Okay, let's say I'm going to throw one off the wall here. I've run into this problem. I have an LVAD patient.
Oh,
how do I kill them? So, and I say that delicately because, I got called for an LVAD patient who was obviously deceased, but I still have perfusion. And then it was, how in the world do we turn this thing off? And it came down to not being us. It needs to be the LVAD team. But have you been faced with that, and what would your recommendations be?
Not that often, but if the LVAD is still perfusing enough, the patient's technically alive, right? They just may not be perfusing the brain enough for them to be conscious, and that's why these patients are hard, because they don't have a pulse. It's constant laminar flow, and the way that we measure a BP is we use an ultrasound and a BP cuff or a Doppler, and we just try to do it that way, and we're only measuring a map in that situation.
Yeah,
so basically, if you have a patient who's unconscious and there's no hum that you can hear, you do CPR just like anyone else, like compressions, the whole works, and you bring them to the hospital. I would almost always transport those people just because it's a little bit more difficult, but you can always call med control. And then if you do hear a hum, the first thing, that's when the question is are they getting perfusion and are alive, but just so little perfusion in the brain that they're unconscious? And the act of CPR can break or dislodge the only thing that's keeping them alive. That's difficult in that situation. So it's I would involve med control and or the number that they have in their little book that tells their team as soon as possible. I'd call both, like if you have two phones, because this is a very tough situation.
And that number for UH and the clinic is also listed in our protocol book for the LVAD teams, and they're very responsive.
Regional,
yeah.
Because they know this happens. If you have an LVAD, you have a very sick heart, and you're very likely to die at any given time for any number of reasons, and so they know that something can happen. There can be a complication, and they want to be there for you guys.
Yeah, it's heart augmentation, not a heart replacement.
Right.
So if it continues to fail in the background.
But you brought up a good point, and even the protocol says you can do mechanical CPR if needed. It's last case effort, but it still works, and it's proven to circulate blood, so you can.
The key is, though, I didn't mention, is if you don't hear hum, before you start compressions, try to troubleshoot the LVAD. Make sure it's plugged in. Make sure it has batteries. Find another any battery source or anything, because if you can plug it in and all of a sudden it starts working again, great. You have the LVAD functioning, and this guy might wake up unless he's been dead for a period if it wasn't working. But if you can't troubleshoot it, then you got to do CPR.
All right. So we've got ROSC, and what things can we do to make sure we've got that we've got all the tools we need to optimize the patient, right? So if we put one IO in like intra-arrest, what else should we prepare, and what else should we do in cases like that?
So I kind of mentioned this as kind of a post-arrest checklist. These are all the things you should do in the post-arrest period to give your patient the best chance of surviving to the hospital where they can get further care. So the first thing you mentioned is if you have only one point of access, whether it be one IO or one IV, get a second one, because we know that extrication and moving the patient could lead to losing that line, and getting one in the back of the rig if the patient's bouncing around and crumping is a lot harder than doing it before you move them. And that's just the nature of EMS. Is you can lose a line pretty easily. So getting a second one, even if it's a second IO, that's okay. That just 2 points of access. Get the 12 lead for all the reasons we already discussed. Have fluids spiked and ready to go in case they get hypotensive, but if they don't need the volume yet, don't start it.
Don't give it to them. Right?
You just want it ready to go. Mix your push dose epi now, because if you do need to give them a little squirt of push dose epi, you'd rather have it ready to go than scrambling while they're hypotensive. And then have your airway plan ready. If you got ROSC really quickly and they're unconscious and you don't have an advanced airway, this is the time to call for RSI or do a drug-assisted intubation, just because if they need an airway, you want to get them something. And it can be a supraglottic. You don't have to end up doing an endotracheal tube if they need something. And then the last thing is obviously leave the mechanical CPR device on if it's already on. And if you got ROSC with manual compression, put the Lucas on. Have it positioned and ready to go so that if you lose pulses, which is potentially likely even despite your best efforts, you're ready to go.
What's everybody's observation been in the post-arrest space with capnographies higher than normal? Are you seeing that your providers, for the most part, pick up that rate a little bit to normalize it, or it's a big number, so we leave it there and bag once every 5 to 6 seconds, like ACLS says? Because I've experienced a mixed bag. I've seen some providers, like, oh, I need to do something about that. That's a tangible
at least
thing.
for our shift, our department, we're pretty proactive. We'd pick it up and try to blow off some of that. But you guys?
Yeah, I mean, I think we do the same thing. I think when obviously you achieve ROSC and it skyrockets, you're thinking about all those other things of preparing, and we take our time to load up. And yeah, I believe we adjust our ventilation as needed, to try to get to 40 as best we can. Yeah.
And that's exactly what you should do. The reason that we say in cardiac arrest we only bag at the pre-designated rate is because we don't have end tidal with perfusion to base it off of. So we know that hyperventilation in arrest is bad, and that we as humans are likely to hyperventilate just because of the adrenaline of resuscitation. That's just part of it, and that's okay. But we want to make sure that we don't do that. But once we get ROSC, this patient may have been hypoventilating before you got there, before you got an airway. Maybe the number of breaths we were doing intra-arrest was incorrect and they needed more. Yeah. But now we have a number to tell us what we need to do, and we should balance and hyperventilate to a normal level if we need to.
Yeah, you have an objective, tangible thing to resuscitate to now. You don't have this...
Don't overshoot.
But again, like you said earlier, I mean, now that we've gotten ROSC, treat your H's and T's.
Right.
It doesn't stop. And I always feel like people think, well, H's and T's stop once I regain pulse. Because I fixed it. Well, no, continue those.
So the H's, right? If that number is 70, if that end tidal is 70, right? That means something. That's just not a high number, and it's better than a low number, right? That means acidosis, right? Right. Yeah. That's, it all circles.
It doesn't mean anything until they have a pulse, Scott.
But it circles back to that, right? We're taught H's and T's, and I don't know that we I think a lot of people need to frame that mentally differently, right? Rather than running this ACLS checklist in their head. Yeah. But they need to know that number means something clinically. It's not just an arbitrary number of, higher is better kind of mindset.
Higher's good, but not better.
Out of range, right?
I take it over low, okay?
Well, I think to your point too, people see the H's and T's as, okay, I've ran my gamut. I'm in a systole. This is my checkbox to essentially call in and field terminate, right? And then we're essentially saying, okay, in that mindset, but it's applicable in other places as well. Like, so you got ROSC, or now that we have ROSC, you need to maintain it, and you might have to adjust some of those things that involve the H's and the T's. So just be cognizant of those on both sides of the field.
And that is also dynamic.
You have ROSC and you're taking them to the hospital, or you're doing field termination. So. It's both ways.
Since we're getting since we're hitting everybody's hot topic buttons, should I just throw my question out there to get my hot topic answer out of the way? All right. Your oxygen's cranked all the way up. You're bagging your patient.
I know where you're going with this. Pulse ox doesn't stop at 100.
No, we'll say the pulse ox isn't coming up. Let's say it just plateaus at 88, 90, despite the fact we got good rise and fall of the chest. I know the tube or my supraglottic is where I've got good end tidal tracing, so I mean I'm where I need to be, and but sadly I'm preaching again to something that is not a tool everybody has, and that was consideration of adding PEEP, right? Because if that patient was not in cardiac arrest and you put him on a non-rebreather and the SATs didn't come up, what would you do? You would recruit some more alveoli by putting them on CPAP. And you have the same functional physiology with a PEEP valve, right? But I think it's an underutilized. I guess we're going to get all our air all of our laundry today since he got us on. But if you have access to a PEEP valve or you're forward thinking enough to have that in your kit, right? That's the patient for that, right? Again,
does every standard bag valve mask come equipped to handle a PEEP?
Come equipped to handle? I haven't come across one that won't handle.
You just pull off the blow-off valve and then you should be able to put it on.
Does it come with one? No.
No, but I'm just saying.
That's where I was at when you guys all started going that way. I was
that's a purchasing choice.
No. Yeah,
that's a purchasing choice.
If you're in the ER, you can always grab one from respiratory though and throw it in your bag.
So you have to be careful. Essentially, just buy it as a kit. There's some nuance there.
Pulmodine makes a really good new BVM.
Okay. Shameless plug. Got it.
They really do.
There is.
Buy now for 50% off.
Use code Ferroni.
I had to do it. Sorry. My bad.
I'm getting a cruise. Did I tell you that?
There's some nuance to how PEEP valves fit on various exhalation ports on BVMs. So unless you're super well equipped and understand that, just buy it as a set. I think is the safest play. Don't try to cobble it.
But to your point, it is underutilized. We can augment. But why not just fix it?
Well, at some point the knob stops, right?
Yeah. Yes. Or falls off.
Just breaks off, falls on the floor. Seems about right. So we talked about optimizing oxygenation. We've talked about some strategies for optimizing CO2. We've talked about perfusion, hemodynamics. Anything else in that post-arrest? What if I got a really stupid, ugly, wide QRS on my EKG?
Yeah, so if you think if it's a really wide complex that it's from hyperkalemia, which is entirely possible, low threshold to give calcium to these patients, maybe that's what killed them, or maybe it happened from arrest. And then the other thing is, if you do have an unstable tachyarrhythmia, low threshold to just electrically cardiovert. Don't try to be too finessey with medications. This person is probably unconscious. You don't have to sedate them. So just quick synchronized cardioversion, low threshold for almost anything, even if it's AFib with RVR. Like, we got to control this hemodynamic as soon as possible.
Yeah.
You should treat all tachyarrhythmia as likely unstable in the post-arrest setting.
That's a great point.
No, that's really what I wanted to hear was the low threshold for, and I guess more importantly, if you're wrong, the risk is low.
If you shock someone who doesn't need it, it's just going to hurt them. And if they're unconscious, they're not going to feel it anyways. But if you fail to shock someone who does need to be shocked, they could easily arrest, or in this case, re-arrest, and that's what we want to prevent.
I was maybe hurting them unconsciously or killing them by not doing anything.
Right.
Yeah, I was speaking more to the hyperkalemia and the use of the calcium and the bicarb. Yeah, again, well, even if it's just wide and ugly, right?
If you shock hyperkalemia, nothing will happen.
Yeah.
And so if that's the case, then try calcium if it's really wide.
Yeah. But even that low threshold, if you're vacillating, isn't it?
Yeah.
If you just give it, the benefits far outweigh the risks of a couple grams of calcium and potentially some bicarb. So
And then one other thing, which I've noticed a few times, is low threshold to put this unconscious post-cardiac arrest patient in a C-collar for two reasons. They may have died because they broke their neck, right? So somebody may have tripped and fell, and we just assumed it was a medical reason for a fall, but in reality, they just fell because they tripped, break their neck, high C-spine fracture, they stop breathing, and then die of hypoxia, but then we get ROSC. So that person has an unstable C-spine. Or it was a medical cause for an arrest. They had a heart attack or a stroke or something, and then they just fell to the ground and broke their neck because of it. This person is likely unconscious, and we can't medically clear their C-collar or C-spine. So if we put them in a collar, which will help prevent the ET tube from being dislodged if we have it from their head moving around, and will protect their neck if there already is an injury. So it's kind of low threshold to put them in a collar in these situations.
Yeah, and that's a best practice. It's baked into the protocols anyway. It's like consider C-collar on these patients just for no other reason than to keep that airway from.
So what do we do,
moving
Doc, in the case of the ROSC patient who starts fighting us, grabbing at the tube? What would you like for us to do?
So this person needs to be sedated. They're inhibiting your ability to resuscitate them, and they're going to need something. The good options that you have is ketamine and Versed. We can't really use ketamine in this patient unless they have an advanced airway, and that's the indication for sedation. We can use Versed in all comers, but if you think ketamine is the right choice and it doesn't meet our protocol criteria, this is a quick call to med control and get permission, because you might be right. Maybe ketamine is the right choice, and we have to bend the protocol, and the physician will give you permission. Most likely.
Okay to do that.
Yeah.
More importantly, the take-home point out of that should be the benzos will fit everybody, and I don't need to call for that, right? So I can start with that as I'm like, I need a backup plan, right?
And if they're hypotensive, just remember that even a small dose of a benzo could drop their pressure, so they might need to be chased with a little bit of push-dose epi just to kind of sedate and get their blood pressure up.
That brings me to, I don't say pet peeve of mine, but a concern that I've seen a few times is we're running the fluids and they're waiting for the pressure to come up based on the fluids, and do those things concurrently, right? We're out of the game of, well, we're going to wait for the bolus to work before we do the next thing. We're out of that game, right?
You can do both simultaneously.
You can do both simultaneously. Squeeze that, put a pressure infuser on that bag while you're tapping.
Would be that it's a hemorrhagic patient. I mean, stop the bleed first, then fill the pot.
Talking in a post-arrest setting.
So we should be treating trauma patients very different than medical patients. 100%. If you think they're dying of bleeding, you're exactly right. They're a very different person or patient than somebody who's died of a medical reason.
Yep. And that was going to bring me to my next point, was how do we treat a traumatic arrest differently than we treat, post-resuscitation? So what's the differences here? I know that we can't use... I keep hearing, you can't use a Lucas on trauma arrest.
So you absolutely can use a Lucas on a trauma arrest, but the thing is, if somebody died in trauma, most likely it's because they exsanguinated, and there's literally nothing we can do to fix that. And so if you have someone who you get to the scene and they died of blunt trauma and there's no signs of life when you got there, that meets DOA criteria. And the best thing to do would be to call and pronounce them. If they're still entrapped and in cardiac arrest, that even if it's penetrating, that is almost positively going to be a DOA
criteria.
For all these patients, what I would recommend is just while you're calling med control, just needle both sides of the chest, because if it is a tension pneumo, you'll get ROSC quickly and you can actually take them somewhere. But if needling them does not save their life, they're likely 99.9% not going to be savable.
And it makes the trauma centers happy. Makes the trauma centers happy too, because it's one of the things that we have to try to do better on, is making sure that we do needle decompressions for the rule outs in a trauma arrest.
Yep.
The only exception for trauma arrest is if it's a penetrating trauma that you witnessed, not that you witnessed the trauma, but you witnessed the arrest component, and you could get them to a trauma center in under 5 to 10 minutes from the point of witnessed arrest. Then it's reasonable to transport. But even then, I would call to notify, because they may say, you know what, even then survivability is exceedingly low, and they may say, hey, drive safely, pronounce the patient, and we'll see you guys in a little bit.
Yeah, and thanks everybody for joining us. That was that was our cardiac care special with Dr. Singer here. So we'll see you next time. Thank you.